Hello and welcome to Journal Club this week. So this week we have Dan and Tammei who are going to present about CRASH 3 study. So I'll hand you over to Dan first to present. Okay, over to Dan now.
That's great, thanks, Seham. This is a joint presentation with myself and Tammei. And obviously, Tammei's on maternity leave at home, so we're going to do this as a bit of a sort of a joint double act. So I'm just going to start and just give a bit of a background to the study and why it was done, and just a bit of a sort of a warm up, as it were. And then Tammei's going to go into the real details of the study, as it were. So as Seham said, the Journal Club today is on the CRASH 3 study. So that was a clinical randomization study of using an antifibrinolytic therapy in significant hemorrhage, and it's a part of a sort of a series of research trials. So it's the third in that trial. So the study in particular, what did it look at? So essentially it looked at the role of using tranexamic acid in patients with traumatic brain injuries who had or who were at risk of having a significant intracranial hemorrhage. So it was just basically to see the efficacy of using that treatment in that clinical condition. So why is it important? So well, traumatic brain injury is actually a fairly common, relatively common presentation. So actually, it's relatively common. So if there's anything we can do to improve the consequence of that, then that's obviously beneficial. Now, traumatic brain injury is often associated with intracranial bleeding, and we obviously know that any blood within inside the cranium that's extravascular is obviously not a good thing. And not only is it important because yes, bleeding can happen at the time of injury, but actually it can also be delayed. And that delay of maybe a couple of several hours actually gives an opportunity, if there is possibility for treatment, if there's proven treatment that's safe, then actually that gives us something to hang on, really. So that's why it's important. And intracranial bleeding, as we mentioned previously, is a significant problem. So obviously we're all aware of the cranium being an enclosed space. Increasing having a bleed within that space can raise the intracranial pressure, which can then obviously lead to brain herniation, as the picture on the slide shows, and obviously then can lead to death. So it's obviously a very significant condition. As I mentioned earlier, the CRASH 3 trial sort of followed on from the CRASH 2 trial, which looked at a more sort of general use of tranexamic acid. This was a study between 2005 and 2010, and it was a multi-international centre study, and it looked at using tranexamic acid in bleeding from trauma, and not just intracranial. So it was all, I've actually written extracranial there, but it was all types of trauma. So we'll go into that in a bit of detail, just to give a bit of background of why tranexamic acid may be useful. As I said, the CRASH 2 trial, the results were published in 2010, and it looked at the assessment of using tranexamic acid in hemorrhage trauma patients. And they actually found that using tranexamic acid in these patients reduced all types of mortality, so all-cause mortality, by up to a third, and that's not just hemorrhage. Interestingly as well, the study showed there was actually no significant increase in adverse effects by using tranexamic acid. So there was no increase of PEs, DVTs. It was significant by using this treatment. So that's sort of a bit of a background of why CRASH 3 was potentially brought forward. Okay, so talking about tranexamic acid, that's the treatment that they chose, and we'll just give a little bit of background about what tranexamic acid is. So it's actually a lysine analog, and its role is in the clotting pathway as depicted on the flow chart on the right. So if we all remember our hematology from med school, remember that there's an important step that's involved in the breakdown of fibrin products, so i.e. a clot, and that involves the conversion of plasminogen to plasmin, to then be able to create fibrinolysis to break down a clot, essentially. So what tranexamic acid does, it basically inhibits the conversion of plasminogen to plasmin, Okay, so that basically means that the degradation of the fibrin products doesn't occur. Okay, so essentially that's where it acts, and that's why it's important. We are aware, obviously, every medication has risks, has side effects, and obviously by virtue of the way it works, the mechanism of action, then it can increase the risk of, theoretically, of clots. And I think we had I don't know if everyone remembers, probably about 2 months ago on the ward, we had a young lady who had very sadly had a venous sinus thrombosis, and there was maybe an implication of tranexamic acid being a contributing factor in that. So we are aware that these medications do have side effects. And obviously we've got to be aware that it can have increased side effects in people with renal impairment, liver impairment, and pregnancy. So that leads on just to the final slide that I'm going to do, just to sort of a basic background of CRASH3 before Tanmay takes over. So what did CRASH3 look at? Well, again, it was like CRASH2. It was an international, multi-center, randomized controlled trial. It ran from 2012 to 2019 for data collection, and it basically looked at patients who presented with a traumatic head injury with an intracranial bleed, and it basically looked at what would be the effects of using tranexamic acid versus a placebo on, first of all, the 28-day mortality, and then actually sort of secondary outcomes, such as, does it affect disability outcomes? Is there increased risk of vascular occlusive events, so i.e. those PEs, those DVTs, and are there any other increases in comorbidity, so things like seizures, essentially. So that's where I'm going to finish, really. That's just to give a bit of a background, and I'll let Tanmay take over, and then we can answer questions at the end together. Okay, thank you.
Okay, thank you, Dan, for your presentation. And now I'll be continuing with mine, which is basically the CRASH3 trial. And I'm sharing my screen now. I hope everybody can see that.
Yeah.
Yeah, okay, cool. So, so the CRASH3 trial is basically seeing the effects of tranexamic acids on tranexamic acid on death, disability, vascular occlusive event, and other morbidities in traumatic brain injury, which is basically a randomized placebo-controlled trial. So as we know that there are more than 60 million new cases of traumatic brain injury every year, and the most common cause for these injury, for the traumatic brain injury, is road traffic accident or fall. And these traumatic brain injuries causes basically intracranial bleeding, and then subsequently, as Daniel already said, that it increases intracranial pressure, and which can subsequently lead to brain herniation and death. So, as Jen already said, that the tranexamic acid reduces bleeding by inhibiting the enzymatic breakdown of fibrin clots. So it basically enhances clotting. And as it's the effect of tranexamic acid in general trauma has already been shown in CRASH2 trial. So basically the aim of this study is to quantify the effect of tranexamic acid on head injury related deaths after traumatic brain injury, the disability which is caused by traumatic brain injury, and adverse event followed by traumatic brain injury.
I know you didn't see him. What are the doctors? Well, which one? You say your presentation.
So yeah, so basically CRASH3 trial is an international trial. It's a multi-center trial, randomized placebo control. So it was basically done in 175 hospitals in 29 different countries. So this trial was started in July 2012 and through 7 years till 31st January 2019. In total, around 12,737 patients were randomly allocated between two groups. So one is the treatment group, and the other group is basically the placebo group. So the eligibility criteria uh, of eligibility criteria of this trial was the patient should be adult, and the trauma should be, the presentation should be within 3 hours of injury, and the patient should have the Glasgow Coma scaling score of 12 or lower than that, and CT scan findings showed intracranial bleeding, and there should be no major bleeding anywhere else. So this is the flow chart, which basically shows the randomization of the patients. So there were 12,737 patients, which were divided into two groups: the treatment group, which include the tranexamic acid group, the other group, which is placebo group. So around 4,649 patients are randomly assigned within 3 hours for the tranexamic acid group, and 4,553 assigned to the placebo group. So what have they done? They basically, when the patient came to A&E, and within 3 hours, they gave tranexamic acid, the loading dose. So the loading dose of tranexamic acid was 1 gram, which was given by infusion over 10 minutes. And this tranexamic acid loading dose was followed by an intravenous infusion of 1 gram over the next 8 hours. Or the other group, which includes the placebo group, which is basically normal saline. So every patient was assigned a unique number treatment pack, so that basically they can blind it. And the outcome data were collected 28 days after the discharge or death. So what were the outcomes that they have decided during the trial? So the outcome were like primary outcome and the secondary outcome. So the primary outcome was head injury related death in hospital within 20 days. And the secondary outcomes were like early head injury related death within 24 hours after the injury, all cause or specific cause mortality, disability, vascular occlusive events like myocardial infarction, pulmonary embolism, stroke, seizures, other complications, neurosurgery, number of days in intensive care unit, and adverse event within 28 days of randomization. So they did the statistical analysis with an intention to treat basis. For each binary outcome, they calculated the relative risk and 95% of confidence interval. The effect of tranexamic acid on primary outcome was basically stratified into 3 baseline characteristics, like severity of head injury, like mild, moderate, and severe, time to treatment, like within 3 hours or more than 3 hours, and the age. The severity of head injury was assessed by the GCS score and the pupil reactivity. So the results were that tranexamic acid is more effective in less severely injured patient. So the p-value is 0.007, and with reactive pupil, the head injury related deaths were reduced with tranexamic acid group. So the relative risk ratio is 0.87 in those groups. So this is the table which basically shows the results between the two groups, like tranexamic acid group and the placebo group. So first category is all the patients included in the study, and the other categories excluding the patient with GCS of 3 or bilateral unreactive pupils. So as we can see here that the relative risk is 18.5 in all patients in the general category, and versus a placebo 19.8. If we exclude this, so the relative risk is 12.5% in tranexamic acid, and 14% is in placebo group, which shows that the relative risk of death is less in tranexamic acid group in comparison to placebo. So the other table is basically shows that the effect of tranexamic acid on the severity of injury, severity of brain injury. Like if we talk about GCS or we talk about pupil reactivity. So for GCS, like mild to moderate severity of injury, the GCS was 9 to 15, and the relative risk is 5.8% in tranexamic acid group versus 7.5 in placebo group. So we can see a line here. So basically on the left of this line, which basically favors the tranexamic acid treatment, and right side doesn't favor the tranexamic acid treatment. So for mild to moderate severity of injury, basically it shows that the relative risk is 0.7%, and majority of the data is on the left side of this, which shows the favorable outcome in mild to moderately severe patients. If we talk about severe head injury with a GCS of 3 to 8, which shows that most of the readings are, the majority of the readings are almost on the line with the relative risk of 0.99, which shows there is barely any benefit of tranexamic acid in this group. Apart from that, if we talk about pupil reactivity, if both pupils are reacting, so again, which both pupils are reacting means, yeah, the GCS is good, and then neurologically the patient is not that bad. So in tranexamic acid group, the relative risk is 11.5 versus 13.2 in placebo. Again, the most of the readings are on the left of this side, which shows that the relative the tranexamic acid has got a favorable outcome in these patients with the bilateral pupillary reaction is there. If we talk about non-reactive pupil, so again, the relative risk is very high of death, like 52.3% tranexamic acid, and in placebo 50.8. So there is basically no difference in between tranexamic acid and placebo group. So if we talk about these data, so this is almost on the right of this line, which shows that the benefit is not much of tranexamic acid if we give in this group patients. So this is another figure which basically shows the results of this trial in terms of time to treatment. So the left side of the graph is a mild to moderate GCS score, and the right side of graph is severe GCS score. So if you talk about mild to moderate, the time to treatment is on the x-axis from 0 to 240 minutes. And on the y-axis is basically the risk ratio of 0.58 to 1.25. So as we can see in this, that as the time increases, this graph is basically reaching up to 1. And if the relative risk, if the risk ratio is less than 1, which shows the favorable outcome with tranexamic acid. So as the delay is increasing, so so this the risk ratio is approaching towards 1, which means that if we give the medication within a particular time window, only then it is beneficial to the patient. Otherwise, if we give after 240 minutes, basically the outcome is not that great. So this is what has been shown in mild to moderate GCS score. On the other hand, if we see this figure with the severe GCS score patients, so we barely see any difference in the time of treatment and the outcome. So basically, which shows that tranexamic acid, whether it is given earlier or later, shows no great outcome. So the relative risk of the head injury related patient within 24 hours was 0.81, which is fairly okay. And when the patient's GCS score is 3 or with bilateral unreactive pupils at the baseline were excluded, so the relative risk fell to 0.72, which means that the severity of the head injury is basically one of the main determinants that whether the tranexamic acid is going to show the good outcome or not. So they also assess the effect of tranexamic acid on the disability in the survivors by comparing the mean disability rating scales score, which basically means the lower score means less disability. So mean scores are basically similar between placebo and the tranexamic acid group, which shows that there is no the disability wise between these two groups, there is no difference between these groups. So, and also the vascular occlusive events like acute myocardial infarction, pulmonary embolism, DVT, there is no difference in between these groups. Risk of the seizure as well, there is no difference. And the number of adverse events are also similar between these two groups. So this is a table, which is a big table, a lot of numbers there. So I don't want to go into much details of it. Just want to tell that the disability which they measured were these factors like confinement to bed, inability to wash or dress. So if we see like the numbers are not very different in these both groups, like tranexamic acid group and placebo group, less than 3 hours of administration. So if we talk about confined to bed, so the relative risk is 12.5% in tranexamic acid and placebo is 12.2%, which is almost the same. So similarly, if you talk about complications like all vascular events, so the relative risk percentage is 1.5% in tranexamic acid and 1.3% in placebo group. So there is no much difference in terms of vascular complication as well. And seizures is also 2.8%, 2.3%, GI bleeding 0.3 and 0.5%. So there is almost no difference in complications between a tranexamic acid group and placebo group. So this trial basically provides evidence that the administration of tranexamic acid to the patient with traumatic brain injury within 3 hours of injury, it reduces the head injury related death in patients with mild to moderately severe injury, and with no clear-cut, with no evidence of adverse events or complications, and there is no increase in disability among the survivors. The early treatment of patients with mild injury and moderate head injury seem to confer the greatest mortality benefit. This is consistent with the hypothesis that tranexamic acid improves outcome by reduces the intracranial bleeding, of course, after the traumatic brain injury when there is a trauma. So the chances of bleeding is more during the initial hours. So if we give the medication in the initial hours, definitely is going to affect and is going to show the benefit. And after brain injury, there is a hemorrhage, and the hemorrhage expansion occurs immediately in immediate hours. So the treatment delay, that's why, would reduce the potential for tranexamic acid to prevent intracranial bleeding. So in patients with severe head injury, the chances of survival are less, and the patient have already had very severe hemorrhage inside the brain. So there are very less chances that tranexamic acid is going to show its benefit. So yeah, so this is all about the trial, and these are the references. So I hope that I have properly told everything about the trial almost, and therefore I'm stopping here, and will welcome everyone to raise questions.
Okay, thank you, Tanmay and Dan, for your presentation, especially Tanmay while doing this on your paternity leave. We've only got a few minutes before this meeting is going to end, so I'll open the floor up to any questions for anyone. So I'll start at the moment. Do you think that we should be giving tranexamic acid to the patients who are having a mild kind of light reduction in their GCS after a traumatic brain injury? Do you think that should be routine for us to do that?
Yeah, I think we should give. This is what the trial shows, because this is a big trial. If you talk about traumatic brain injury, crash CRASH 3 trial is a big trial, which basically include around 12,000 patients, and it is done in various countries and various hospitals. So I think it should be a routine, and I think most of the major trauma centers are following this. They should give tranexamic acid within as early as possible and try to give within 3 hours. But yeah.
Yeah, I think yeah, the study did show safety, efficacy, which is good. I think we still have to be mindful that there are risks associated. So I think we would have to caveat that I think there would need to be some provisions put in place for those who do have like an AKI, a renal impairment, or hepatic impairment, those who are pregnant, for example. So I don't think it's a one fits all, but I think the study definitely shows the use for using it, and it's relatively safe. So yeah, I think it'd be useful to use.
Okay, thank you. Right.